Microneurosurgery of the brain. Yeah, we are live now.
Yeah, we're online. I'm going to start. Okay.
Yes.
Muy buenas tardes a todos. Continuando con el programa de hoy, a nombre del señor embajador de la UNESCO, Jorge Herrera Ramos, y chairman del World Congress of Neurosurgery, UNESCO ESPNATE, Walter E. Dandy, in honor of Professor Jarsar Hill, a quien agradecemos por la organización de este magno evento, así como a la doctora Deyanira Capi Casillas, chairman del capítulo ANS-IPN, al doctor Salim Abdul Rauf, chairman de la Walter E. Dandy Neurosurgical Society, al Dr. Babak Kateb, chairman de la Society for Brain Mapping and Therapeutics y de Brain Mapping Foundation, todos ellos vice-chairmans del comité organizador, y al Dr. Parmenis Guadarrama Ortiz, chairman del Centro Especializado de Neurocirugía y Neurociencias, México. Es para mí un honor presentar la siguiente ponencia a cargo del Dr. Hischam Bassiouni, director de los departamentos de neurocirugía de los hospitales académicos Klinikum Amberg y Klinikum de Baviera, Alemania. Con subespecialidad en neurooncología, neurocirugía vascular, base del cráneo y neurocirugía pediátrica, es miembro de la junta editorial del Journal of Neurosurgery, Imaging and Techniques y microcirugía del cerebro. Hoy nos va a hablar sobre microcirugía del cerebro, lecciones aprendidas y consejos enviados. Ready. Dr. Natalia, can you introduce?
Yeah, thank you, Dr. Francisco, for the nice introduction in Spanish. So we are welcoming you for the second lecture for today. It is the second week of the World Congress of Neurosurgery, UNESCO and Walter Dandy Society in honor of Professor Jarsar Hill. And we are actually doing all this on behalf of the ambassador of UNESCO Associated School Networks, Jorge Herrera Ramos, President of the World Congress, to whom we are grateful for organizing and to putting together all these different neurosurgeons and lectures in one, and also to the Vice President of the World Congress, Dr. Deyanira Capi Casillas, President of the WNS IPS Student Chapter, Dr. Salim Abdul Rauf, World President of Walter Dandy Neurosurgical Society, and Dr. Babak Kateb, President of the Society for Brain Mapping and Therapeutics and Brain Mapping Foundation. Our honorary chairman of the committee is Professor Nasser El Gandour and Professor Marcus Rota, and also Dr. Parmenides Guadarrama Ortiz, Director of the Specialized Center for Neurosurgery and Neurosciences in Mexico. So today we have our speaker from Germany, from beautiful Bavaria, Dr. Hischam Bassiouni. I'm sorry if I'm not doing it correctly. He's the director of neurosurgical department of Klinikum Amberg and Klinikum Weiden Academic Hospitals in Bavaria, Germany. Subspecialty in neuro-oncology, vascular neurosurgery, skull-base surgery, and pediatric neurosurgery. So it's really great. And we would like to listen to your lecture, doctor. And yeah, you can start.
Thank you very much for this nice introduction. And yeah, good evening from Germany. It's 1 hour before midnight. And so good evening to the rest of the listeners in this global event. My topic is about brain microsurgery of the brain, the lessons I've learned. I'm now a bit more than 30 years in the field of neuroscience, neurosurgery. And so the lessons I've learned in this time and the advices I can forward, of course, this is a personal perspective, so it's my own. I don't know if you can see my screen. Can you see it?
Yes. We see everything is all right.
Okay.
Yeah.
So I thought of delivering, because it's mainly an educational webinar, so I would like to deliver an ebook. This is the cover of the book, and I have 7 chapters. So beginning with chapter 1, the pillars of success, or back to the roots. I think you cannot achieve surgical mastery without considering these pillars, and it begins with talking to the patient. You learn a lot of talking to the patient. Take your time talking to the patient, and knowing about his present complaints, knowing about his past history, about his family history, medical history, and so on. And this should be followed by clinical examination. It should be very accurate, and this gives you hints to, if you find deficits, give you hints to the topography where the lesion lies. So built on these both, you get specific neuroimaging, which usually in our case, on our topic, includes a brain MRI. And you have to analyze these images very carefully in order not to miss any information you got from these images. And the fourth pillar, I think, is an in-depth knowledge of anatomy of the brain, the topic of this speech. And of course, you have also to practice your skills, and you can practice your skills in the laboratory if you've got one, or visit courses. Of course, at the moment it's a bit difficult because of the COVID time, but otherwise it was free of visiting. So you have to practice your skills. So built on this, you've got a sound indication for doing surgery or not doing surgery, and you can achieve surgical mastery. And you complete this and build the pyramid or the top by getting an optimal result, surgical result, and patient satisfaction. So in regard to anatomical skills and anatomy, of course, this legion of neurosurgical anatomy does not need any introduction. It's Professor Albert Rothon, who dedicated his life for surgical neurosurgical anatomy, and I strongly recommend to read his papers, to read his books, and to get an in-depth knowledge of the anatomy. And this is these are just a few of the images of his books on topography, vascular neurosurgery, skull-based neurosurgery, and approaches. Of course, he has got thousands of unsurpassed images, and even very experienced neurosurgeons still read and learn from him. So the message in chapter 1 is, despite the technological advances we have achieved today, don't forget about these basics and apply them in your daily practice, so they should go into your daily routine. And don't forget what Lars Lexell, a neurosurgical and radiosurgical pioneer, once said: a fool with a tool is still a fool. So even if you got all the technology in your institute, in your clinic, if you don't consider these basics and apply them, you will not achieve, in my view, surgical mastery. The second chapter is about complications, and this is a chapter usually surgeons do not like to talk about it, at least when it gets to their own complications. And French vascular surgeon René Leriche, maybe you know him from the Leriche syndrome of the aortic arch, once said every surgeon carries about him a little cemetery in which from time to time he goes to pray, a cemetery of bitterness and regret, of which he seeks the reason for certain of his failures. And this sentence is very true. I would like to give an example in the treatment of aneurysms. These are two images from the publication seen below. You see that with time, in the pre-microsurgical era, the approaches were quite large. They were not focused. Then in the early microsurgical era, they were more focused, becoming smaller. And of course, this was the time when Professor Yajagil introduced his Trigeminal approach, which is still in use today. But with further development, these approaches became smaller and smaller, and this is the mini-terminal craniotomy or the supraorbital craniotomy, and even you see a surgeon performing clipping of aneurysms endoscopically via the transnasal transsphenoidal approach or via the supraorbital approach. So I also was and I am enthusiastic of minimization of these approaches, and I would like to give you an example. A 53-year-old man who presented with an epileptic fit, and during neurological workup we found an unruptured right-sided aneurysm, which you can see here. We discussed it with the patient, and also, as we usually do in an interdisciplinary together with the patient and together with my interventional urologist. First, we decide whether to treat or not to treat, and so this was for treatment, and what treatment is better for the patient, and we decided together interdisciplinary that clipping was the preferred method of treating this aneurysm. So this is the angiography performed before surgery. You can see the aneurysm here in the 3D reconstruction. And this is the surgical setting, positioning, and the small skin cut behind the hairline. And hope the video works. This is the skin cut. It's around 5 centimeters. You dissect the sylvian fissure. Surgery is performed without fixed retraction. So this is the aneurysm. This is the branch which is adherent, an M2 branch adherent to the aneurysm, which is separated from the aneurysm. And here you've got the aneurysm performing an intraoperative angiography before clipping, an Icg angiography, and then clipping the aneurysm, in this case with 2 clips. So after clipping, you can check with the Doppler probe and see the patency of the normal vessels, of the parent vessels, and then perform a control Icg angiography, and you see that the aneurysm is occluded with a patency, a preserved patency of the normal vessels. So this is the angiography after surgery. This is before and this is after, with complete occlusion of the aneurysm in the 3D reconstruction. And this is the approach in 3D CT scan from another patient, but this is around 2 to 3 centimeters, this craniotomy. This patient was also treated, another patient was also treated for pericallosal aneurysm. So this is the patient after surgery, no deficits, and this is early. This scar will not be visible after a while. This is the result you want after such a surgery. And one day I got confronted with this patient who had 10 intracranial aneurysms, a lot. She had in her family history, her sister and mother died of an aneurysm, subarachnoid hemorrhage, and there was on follow-up a growth progression of some of these aneurysms. She was 56-year-old, and you can see the angiography with aneurysms, several aneurysms, 3 aneurysms on the right-sided MCA, 3 pericallosal aneurysms, 2 internal carotid aneurysms, 1 contralateral directed medially. So this is the 3D angiography reconstruction, visualizing the aneurysms. And this is one of the aneurysms, the contralateral right-sided internal carotid aneurysm, showing growth progression. So we discussed it with the patient, and because of her age, because of the growing of the aneurysm, and of course of her family history, treatment was indicated, and it was decided for surgical clipping. And so the plan was to approach the aneurysms from the right pteronal approach. I chose a mini pteronal craniotomy for the 3 MCA aneurysms: the internal carotid aneurysm, ipsilateral and contralateral. And in second surgery to approach the pericallosal aneurysm. So this is the pteronal approach. You can see the aneurysm. You can also see that these vessels are diseased. They're not normal vessels. So there's certainly a genetic background for her disease. So this is the Icg angiography preoperatively. Clipping of the MCA aneurysms. And performing an Icg angiography after clipping. You see that these vessels are not normal, they are diseased. Then approaching the internal carotid aneurysm on the left side. I'm sorry, on the right side. Then putting temporary clips. So you can see this aneurysm, which is adjacent to the optic nerve, coagulating, clipping, opening the aneurysm, then approaching the the internal carotid artery aneurysm at the origin of the posterior, the PCOM, clipping. So this is the other side, the internal carotid aneurysm, lying medially directed and lying under the optic nerve, which can be approached from this side, and then this aneurysm ruptured. So actually from this small approach and the subsequent brain swelling, I had to stop surgery. And unfortunately, this patient succumbed 4 days after surgery due to the subarachnoid hemorrhage and the brain swelling. So this was a catastrophic result of this surgery. So the message in this chapter, heart chapter, is do your best to avoid complications, but they will happen. You have to face your complications, analyze them, don't forget about them, and try not to repeat them, and perform what I would call an M&M introspection. It is a long surgical tradition of surgeons to blame others, but like the assistant, like the scrub nurse, like the anesthesiologist or the patient itself, but be self-critical and blame yourself first, and face your complication and analyze them. I think it's my personal view that with time, surgery or treating patients makes you humble, and there's no place in my view for arrogance, because this prevents self-education and progressive learning, which is a lifelong and continuous process. So chapter 3 is about preservation of function and life quality. And I would like to show you a video how skills and function can, in this case, save life. Just in slow motion, see, he certainly hears. He sees this baseball, and his motor skill, probably all three together, saved this reporter's life. She was lucky. So I want to begin with vision. This was a patient, 51-year-old woman, who presented with mental disturbance and right-sided blindness. This is the preoperative CT scan showing intratumoral calcification. And this is the bone window CT scan, which shows a hyperostosis on the anterior skull base, which is typical for these tumors. It's a meningioma. So this is the MRI showing this giant, per definition, giant anterior skull base meningioma, and this hyperostosis here. If you look closely, then you see that there is contrast enhancement. So this is an infiltrated part of bone which should be removed if you want to prevent recurrences. So this is the sketches from the surgery. This is the left-sided optic nerve, which is compressed by the tumor, but you have got a nice dissection plane and can remove the tumor from the optic nerve. This is the hyperostosis, which has to be removed in order to get a so-called Simpson grade 1 resection, complete tumor removal, and prevent any recurrence. This is the right-sided optic nerve, which is intimately adherent to the tumor and compressed. And you see, if you compare it with the other left side, and you see there's also rarefication of vascularization. So this is the much more compromised nerve, as you can see here, with indentation caused by the tumor. So the same applies to the vessels. This is the anterior communicating and these anterior cerebral vessels. And you have to separate the tumor from these vessels very carefully in order to preserve any perforating branches or not injure them, and in order to prevent to get any infarction. So this is after removal of the main bulk of the tumor. You see the chiasm here, both optic nerves here. Here's still a tumor remnant, the lamina terminalis and the anterior cerebral vessels here. And after removing this tumor remnant, you've got the pituitary stalk visible. In these large tumors, you certainly, almost certainly, according to my experience, you've got an infiltration or tumor encroaching into the optic canal. So you have to open the optic canals, and you can see here a tumor which has to be removed. So this is a site for recurrence of these tumors. So this is the MRI of the patients showing complete tumor removal. Also including on the CT bone window, this hyperostosis, which has been completely removed. And this is the patient 6 months after surgery. She had no mental disturbance anymore. She was a normal lady. And fortunately, also the vision became better. So this is the vision of the right eye before surgery, almost blind. This was around 1 month after surgery, and this was the vision after 6 months after surgery. Became a normal seeing eye again. Also improvement on the left side after 6 months. So this is vision. About the motor function, extra-axial lesions. This is an example of a large falcine meningioma, which is located and compressing the paracentral lobule in a 60-year-old woman who presented with a left-sided hemiparesis. As you can see here, this tumor and compressing on the motor area. And this is the patient before surgery. She had a left-sided hemiparesis. And as you can see here, she's holding her left leg in order to stabilize her gait. And this is the bone flap for removal of this large meningioma. This is the post-operative MRI showing a complete removal of this tumor. And this is the patient 1 year after surgery. There is still a limp, but it became much better. So the hemiparesis markedly improved after surgery. So what about intra-axial or intrinsic lesions and motor function? This is an example of a 57-year-old man harboring a cavernoma of the precentral gyrus. He had severe paresis and fine movement disorder of his right hand. As you can see here, the cavernoma has bled in several times with deterioration of the function of the hand. We did a functional MRI, but this was not conclusive. So this is also an example that you should not rely on technology and have your own knowledge of anatomy, because this cavernoma is situated in the precentral gyrus in the hand area. So this is functional. This is fiber tracking preoperatively showing the proximity of the cavernoma to the pyramidal tract. So this is the MRI before. This is after surgery with complete removal of this cavernoma, and this is the patient on follow-up. And he showed significant improvement of the right hand movement. So a non-functional hand before surgery became functional after surgery. Again, you can see here his hand. There's still some spasticity in his hand, but he can use it and it is useful. So hearing, the most common neurosurgical treatable disease which affects hearing is the vestibular schwannoma, and I would like to give you a short synopsis on the areas of functional preservation in vestibular schwannoma surgery. The first successful surgery of a vestibular schwannoma was reported to be performed by Thomas Annandale of Edinburgh in 1885. And we can summarize the first half of the 20th century. The main issue was diagnosis of these tumors and survival of the patients. So with very few exceptions of neurosurgical pioneers, mortality was very high, usually around 80 and more. And the tumors were very large diagnosis. So facial nerve preservation was first reported in 1931 by Kane, but it was exceptional at that time and became an issue after the introduction of the surgical microscope, first used by Teodoro Kortze in 1957, and then systematically introduced in vestibular schwannoma surgery by William House, beginning of the 60s, who also introduced the translabyrinthine and the middle cranial fossa approach to these tumors, and had, by the way, a very fruitful collaboration and cooperation with the neurosurgeon William Hitzelberger in LA at that time. Today, we can achieve a functional or an anatomical preservation of the facial nerve in around 95% of the patient, but this strongly depends on the tumor size. So at that time, hearing preservation was not an issue. It became an issue in the beginning of the 80s or 70s. It was first reported in 1954 by Elliott and McKissock, who achieved hearing preservation in 2 of their 3 patients, but was exceptional at that time. And of course, William House selected patients for hearing preservation, and at that time, neurosurgical pioneer in this field, Professor Majid Sami, reported it was 82, and the Congress reported that hearing preservation around 30% of his patients. So today we can achieve hearing preservation in around 50% of the patients, but this also strongly depends on the tumor size and the preoperative hearing, and also on the intraoperative neuromonitoring. I would like to give you an example. This is a 58-year-old man harboring a left cystic vestibular schwannoma. Cystic tumors are a special category. They are more adherent to the structures. And you can see on the preoperative MRI, you can see the cysts, the encroachment of the tumor into the internal auditory canal, and this cyst, which is compressing the trigeminal nerve, and the patient presented with a left-sided hypocouth and trigeminal neuralgia, which is not a very typical symptom in these tumors. But the hearing loss or hearing deficit it is. So this is a preoperative high-resolution bone window CT scan, and you see the funnel-shaped widening of the internal acoustic canal and the pores acousticus on the left side, on the tumor side, in comparison to the right side, where it is normal. And this is positioning of the patient for the surgery. For long years, I used the semi-sitting position for these tumors, but since many years, I'm using the supine or lateralized position, as you can see in the images, and I like to perform a straight incision behind the ear. So this is the intraoperative setting using routinely intraoperative neuromonitoring. This is retromastoid craniotomy. You have to wax any opened mastoid cells. This is a very important step, release of CSF. So this surgery is performed without any fixed retraction, just with your microsurgical instruments. This is after drilling and opening of the internal acoustic canal. And you can see here the normal nerves, and you have to identify the nerve of origin of these tumors, which is usually the superior vestibular nerve, and using this stimulating electrode to identify the optic nerve. And this is the nerve of origin, which is coagulated and cut, remove. And then you develop this tumor with preservation of the nerves in the internal acoustic canal. Then debulking this tumor, and this is a problem, as I said, in cystic tumors. They are very adherent to the neural structures and to the vessels, especially the brainstem vessels. They are large. So this is the trigeminal nerve. This is again, this is the facial nerve here. You can identify. And this is removal of tumor remnants, very adherent to the brainstem vessels. And this is an endoscopic control after removal of the tumor. You can see here the trigeminal nerve, facial nerve. The cochlear nerve was preserved. It is downwards. And this is the brainstem side, just to within 30-degree optic to see and to ensure complete tumor removal. So this is the MRI on control 8 months after surgery with complete tumor removal in the axial and in the coronal view. And this is the audiogram. This was pre-operative. Of course, the left ear was the less hearing ear, and this is the control after surgery. So this hearing, or the pre-operative hearing level, was preserved in this patient with the right side normal hearing. This is the patient after 5 days after surgery. This is the facial nerve function, as you can see here. There may be a slight asymmetry on the left side in the mouth, but otherwise it is normal. And this is the straight skin I use. So the messages of chapter 3 is, of course, you know the primum non nocere, the first do no harm. So every effort should be done to preserve function. And as you have seen in this video with the baseball, it can be life-saving, but certainly this preserves life quality of the patient. And I think we nowadays in neurosurgery have another threshold which is much higher, because I think we usually can improve preoperative deficits and function and actually improve life quality after surgery in I think the majority of the patients. So as you've seen in the eras I showed you of the functional areas of vestibular schwannoma surgery, I think you have to consider, even with technological progress, which is dynamic, that was what was considered good yesterday might not be enough for today and tomorrow. Nowadays, we can achieve around 50% hearing preservation. This might not be enough, maybe in some years where we can may achieve 90% maybe. So it is very important, and I think it's character of surgical mastery, that you should not be satisfied with your own results, but always be eager to improve constantly. Work on yourself for this. So learning from the masters, my chapter 4. I had the great opportunity and chance to visit and to learn from 2 masters given as an example here. Both do not need any introduction. One is Professor Yashagil and the other is Professor Hischam Bassiouni, both at that time in Little Rock, and I traveled several times visiting them, seeing them in surgery, learning about their philosophy of surgical mastery, very much enjoying this time, and they gave me great inspiration during my own personal career. So this is a short chapter, but nonetheless important, and the message is that you should learn from your seniors, your mentors, and master surgeons. Of course, master surgeons are usually not, or maybe in your side, but usually you have to travel. Hopefully in the post-COVID times, traveling will be free again, so you have to visit them and learn from them and watch them during surgery. This is very important. However, with all respect to even the masters, you have to keep your own critical mind, because remember, nobody is perfect, and you should always improve, and maybe you one day become better than your masters. Chapter 5 is Be Gentle to the Brain. And it was one of the philosophies and sentences Professor Albert Rodon said a lot of times: make surgery more accurate, gentle, and safe. And this is a very important sentence you have to consider. And I would like to give you examples of retractableness microneurosurgery. Already the surgeries you've seen were retractableness without fixed retraction, and this is a historical sketches from the book of Fedor Krause, a German pioneer of neurosurgery, in his book from 1908, using this large retractors, which, by the way, were not fixed. They were held by the assistant. So there was no fixed retraction, but large retractors held by the assistant. Some years ago, Professor Spencer and his team published an article, The Quiet Revolution, Retractableness Surgery for Complex Vascular and Skull-Base Lesions. And they concluded that fixed retraction can be supplanted by dynamic retraction with surgical instruments, limiting the risk for retractor-induced tissue edema and injury. And I would also add enhancing preservation of cranial nerves. In this article, describe special instrumentarium which can be used. Actually, I haven't got the special instrumentarium. I use the normal suction device and the bipolar, so I think it can be performed with the normal microsurgical instruments. And they also use the mouthpiece in the microscope. I know that a lot of surgeons are using it. I don't like anything in my mouth during surgery, so it's a personal variant. So I would like to give you examples to this. This is a 27-year-old man who presented with acute headache, nausea and vomiting, and it has had an upper gaze palsy. And the MRI showed a lesion in the posterior thalamus and posterior third ventricle, which was showed a nodal enhancement after contrast. And you can see in the sagittal view that this lesion occluded the upper part of the aqueduct. So this led to this occlusive type of hydrocephalus, which was the cause of this acute headache. So what surgical approach and what is the tumor type in this patient? I used an interhemispheric transcallosal transchoroidal approach. This is the operative setting with neuromonitoring. I like also straight incisions for these approaches. This is the interhemispheric approach, identification of the corpus callosum or the pericallosal artery, then opening, dividing the corpus callosum, release of CSF, very important to gain more space. For this retractableness surgery, entering the lateral ventricle, this is the thalamostrate vein, this is the plexus choroideus, this is the fornix, so you enter in this case medial to the choroid plexus for the transchoroidal approach. This is the roof of the third ventricle with the internal cerebral vein, as you can see here. And these are the terminal branches of the medial posterior choroidal arteries. Coagulation of, this is the foramen Monroy, by the way, and then opening, and you can see the lesion in the posterior third ventricle, posterior thalamus. And using neuronavigation just to check if you are correct. And then removing this lesion, in this case, it was a bit firmer than normal brain tissue. And It was grayish in appearance, so it could be good differentiated from normal brain. So complete removal could be achieved, and during the same surgery, I performed a third ventriculostomy just to get sure that there's a solid connection between the ventricular system and the basal cisterns, because I did not put any drainage in this patient. And then endoscopic control is the callosomarginal pericallosal artery, the opening in the corpus callosum, entering the lateral ventricle. This is the fornix here. This is the foramen Monroy, and this is the fornix arching. Then entering the third ventricle here. And this is the third ventriculostomy. You see the basilar artery and basilar artery bifurcation. This is the clivus, posterior part of the clivus. This is the pons. And this is the posterior third ventricle, showing after the cetus, after removal of this, and CSF flow through the aqueduct. So this is the MRI on the right side after surgery in comparison to the one before. On the left side, showing a complete removal of this lesion, and the sagittal view, you have a patency of the aqueduct, and we performed an CSF study, MRI CSF study, and this shows that the aqueduct is patent, and also the third ventriculostomy is patent, so CSF running through these channels. So this is the patient 1 month after surgery during follow-up, and he had no neurological or memory deficits, and he still had a residual of the upper gaze palsy at that time. This is another patient, vascular with vascular problems, aneurysms. 68-year-old patient with the right MCA and basilar artery aneurysm. You see the 3D angiography preoperatively showing the MCA aneurysm, and this is the basilar artery aneurysm. And this both were approached through a standard pteronal approach with drilling of the lesser wing of the sphenoid, as you can see here. Then identifying the meningoorbital band, which is here, coagulating, cutting the meningoorbital band just to have more space, especially for the basilar artery aneurysm. Then dissecting the Sylvian fissure. And this is the tentorium, dissecting the arachnoid. This is the so-called Lilliquist membrane, which has to be opened to approach the basilar artery aneurysm. This it was a blister aneurysm in the MCA bifurcation, not shown on angiography. So this was an incidental finding during surgery. And this is the basilar artery aneurysm with both posterior cerebral arteries, and this is the opposite oculomotor nerve. This is Icg angiography before clipping. So this is clipping of the aneurysm. This is the clip of the MCA aneurysm, which was clipped before approaching the basilar artery aneurysm. And this is very important to preserve these branches, the thalamoperforating branches coming out from the P1 segment. They should not be included into the clip. And also on the opposite side, you have to check for them. And this is after clipping the aneurysm. This is the angiography, the intraoperative Icg angiography, showing both posterior cerebral arteries, and these are the perforating preserved branches, the thalamo-perforating branches of the P1 segment. So this is the 3D reconstruction angiography postoperatively, showing complete clipping and occlusion of these aneurysms, the MC aneurysm and the basilar artery aneurysm. And this is the patient at the time of discharge from hospital, 7 days after surgery. She has no deficits and yeah, had a normal course. Keep approaches simple. Messages from chapter 5 and 6 will follow after chapter 6 because they are related. So I would like to give you an example to this. This is a pontine cavernoma in a 54-year-old patient. She had 3 bouts of bleedings from this pontine cavernoma, and with each bleeding bout, she deteriorated her neurological function. And when she was referred to me, she had a right-sided 6th nerve palsy, central facial nerve palsy, and the left hemiparesis. So how to approach this cavernoma? Of course, nobody would approach it from the 4th ventricle, because it's very eloquent here, and a very thick layer of very eloquent brain tissue. But according to the 2-point rule, as described by Professor Spetzler, this approach would be the nearest to the brain surface. So one can choose an anterior petrosectomy, but the cavernoma may be too low for this approach. But many would prefer posterior petrosectomy or far lateral approach. But you can also consider the workhorse of the posterior fossa, cranial fossa approach, which is the retrosigmoid approach, the so-called simple retrosigmoid approach. So this is the patient preoperatively. You can see the hemiparesis on the left side. She would walk, but with the help of her daughter. Gait was unsteady, not stable. And you see the abducens nerve palsy and the central facial nerve palsy. As you can see here, the abducens nerve palsy on the right side. Left side is intact. Again, the right side you can see here. And the facial nerve palsy here. So this is the operative setting, the positioning you've seen before in the vestibular schwannoma surgery, same approach. This is the retromastoid craniotomy, opening the dura. Of course, intraoperative neuromonitoring is obligatory in these cases. Very important also release of CSF. This is also retractableness surgery, opening the arachnoid membranes. These are the lower nerve group. This is the facial nerve here. And this is the glossopharyngeal nerve, as you can see here. And this is the vagus nerve. This is the pons. neuronavigation is used just to check the point of entrance to the cavernoma. This is an endoscopic. This is 2 millimeter, just to have a relation. This is a 2 millimeter suction. So it's much enlarged. As you can see here, this is the facial nerve, this is the glossopharyngeal nerve, this is the vagus nerve. And this was actually, the approach was between the glossopharyngeal and the vagus nerve. You can see this pale area of the pons. This was the point of entrance. So using stimulating electrode, so this is entering the lower dorsal pons. This is old blood released from this cavernoma cavity. And this is removing the old blood, the clots, coagulated blood, and the cavernoma itself was located on the posterior side of this cavity, and could be in this case removed en bloc, which is not always the case. They may be very adherent. So this is after removal of the cavernoma and of the clot. So endoscopic control, you see the facial nerve here, you see the glossopharyngeal nerve, vagus nerve, this is the accessory nerve. And also the bulk in the pons has much reduced if compared to before removal. This is the cavernoma, the resection area. And this is the basilar artery in front. So there's no cavernoma remnant. So then removing the patties, and this is the space you gain after release of CSF. So no fixed retraction is required for these surgeries. Closing any, this is very important, closing any mastoid air cells, and this is the approach, which is around 2.5 centimeters in diameter. So this is the specimen, the cavernoma specimen removed, and this is the MRI before and after removal with no residual visible in the also in the axial view. And this is the patient 3 months after surgery. The left-sided hemiparesis has almost completely improved. Now she can walk steady and without any help. She still had double vision, as you can see here. And now she shows that she can comb her hair again, which was not possible before surgery. And you see that also the abducens nerve palsy improved. The facial nerve palsy improved, and also, luckily, also the abducens nerve palsy, as you can see here. And the facial nerve palsy. So a few months ago, Professor Spatzler gave a webinar, a presentation, it was in May 2020, and gave about his personal evolution in transpetrosal skull-base surgery. And as you can see, this was his personal experience that there was a hype of these transpetrosal approaches peaking in the 90s. Not only his own experience, but of other skull-based surgeons also. And then this declined, and the original retromastoid approach was used more often. So I think you can get a lot and do a lot in this field with simple approaches in the case of the posterior cranial fossa, with a simple retromastoid approach or some of its minor modifications. Also, you have to choose selectively the approach, as exemplified by this patient, is a 57-year-old man who had a spastic hemiparesis and initially was suspected as having a stroke. And during workup, this foramen magnum meningioma was discovered, as depicted here in the images in the MRI. The vertebral arch is riding on the tumor, and this meningioma is pushing the medulla oblongata backwards and to the left. And there's a controversial discussion in this foramen magnum meningiomas as to which approach is suitable. Should we use a midline suboccipital approach, a lateral suboccipital approach, or a far lateral or fast lateral approach? Whether condyle drilling is necessary and to which extent, and whether vertebral artery transposition is necessary. Interesting, there's no controversy about performing a laminectomy or a hemilaminectomy, even in modern texts of C1. And this includes also our publication on this topic published in 2006, where we routinely performed a laminectomy or a hemilaminectomy. So in this patient, this is the preoperative clinic first. As you can see, he has a limp due to this hemiparesis. And I published this case as a video you can see on YouTube, where I performed a preservation of the C1 laminas. So this is an example of that you have to tailor the approach to the individual patient and lesion. So this is the post-operative MRI after removing the tumor. And as you can see in the 3D CT reconstruction, the arch is preserved. Just a little of the upper rim is removed to approach and remove this tumor completely. So this is the patient after surgery. This is the approach. And this is six days after surgery, and fortunately he had a complete recovery of his hemiparesis in a very short time and has a normal gait, as you can see here. And this was on the day of discharge. So the messages of chapter 5 and 6 keep approaches as simple and as safe as possible. Of course, we have standardization of approaches, but they should always be tailored individually to the patient and to the lesion to be treated. And I think nowadays you can usually avoid fixed retractors because in small lesions, the CSF releases your friend, and you can get a lot of space through this CSF release. And in large lesions, of course, the lesion itself produces the space you need for resection. So the last chapter, treat the patient, not the case, and become interested in your patient. And I would stress 2 points. The first is surgery in the elderly patient, and the second point is follow-up and also long-term follow-up. So surgery in the elderly patients. So this is a very routine clinical situation. An 80-year-old patient coming into the, not coming, was brought into as an emergency into the emergency room. She is pre-comatose and has a right-sided hemiparesis, and the preoperative CT shows this very large intracerebral hemorrhage. So should we do surgery on her? She's 82 years old, I guess, and according to my experience, a lot of surgeons would not do surgery on this old lady with this large hemorrhage. I did perform a surgery by small craniotomy. And this surgery takes around 30 to 45 minutes from skin incision to closure. And this is the CT scan after surgery. And this is the patient 12 days after surgery, lying in her bed, becoming interested in a fashion catalog. I think this is a good example that you should not routinely refuse doing surgery in old patients, but think about it and make it hard make the decision hard for you, not easy. So this is a patient, 80-year-old woman with a large skull base, anterior skull base meningioma. This is the pre-operative and post-operative MRI showing complete removal in the coronal section. In the sagittal section, also removal of this hyperostosis here. And this is the patient on follow-up, having no deficits, regaining a full life quality. This is another patient who had a recurrence of an atypical meningioma, which was located on the tentorium. It is peritorcular meningioma, and according to Icg's classification, T5 meningioma, and she had bilateral incomplete hemanopia and decreased vision before surgery. And you can see here this large area of tumor occlusion of both transverse sinuses. And this is in the sagittal view, and you see also the infiltration of this bone. She had other meningiomas, several ones. This is just one shown here on the falx cerebri. And this was the cetus before resection of this tumor. You see this grayish mass, and this is a typical aspect of atypical or grade 2 meningioma. And this is after resection. The tumor was, because of the recurrent situation, was very adherent to the brain, but could be completely removed, as seen on the post-operative MRI. And in the second stage, also the falcine meningiomas were removed. And this is the patient after both surgeries and regaining a good life quality. This is another patient actually coming, presenting in the peak of the COVID times, although we have other peaks now. But the first peak, and she had an unbearable and medical intractable trigeminal neuralgia. So she was treated as an emergency. We were at that time doing only emergency patients' cases. And this is the pre-operative MRI. And you can see here that this meningioma is centered on the posterior clinoid process and is encroaching into the Meckel's cave. You can see it is included on the right side with a free Meckel cave in comparison on the left side. So this was the reason for her trigeminal neuralgia. So you can see here hyperostosis in the posterior clinoid process on the right side. So this is after removing the tumor, also without fixed retraction. You see the trigeminal nerve, endoscopic control. Here the trigeminal nerve was released from tumor, opening Meckel's cave. So this was a major surgery in this patient. You see here the trochlear nerve, the pons. And so with subtotal tumor removal, and the main goal was releasing and decompression of the trigeminal nerve. And this is the 3D reconstruction with the zygomatic osteotomy. So it's a major surgery in this 81-year-old woman. She was, after surgery, immediately pain-free, and this is the post-operative MRI. On the left side, pre-operative, on the right side, post-operative, with the removal of this tumor and decompression of the trigeminal nerve. And this is the patient 6 months after surgery in a good condition. She is symptom-free and without any medication. So the second subpart of chapter 7 is long-term follow-up. I think this is very important, as exemplified by 2 patients. A 45-year-old woman, she had a subarachnoid hemorrhage due to this large right-sided paraophthalmic aneurysm operated on her in 2001. This was the angiography before surgery, and this was a 2017 control. The aneurysm is still completely occluded. I think this is something we learn from the interventional neuroradiologists. We should do long-term follow-up controls in these patients, because as in this case, you discover or might discover new aneurysms developing, which was not visible on the angiography in 2001. This is the patient. So another patient, this was a very exciting case for me. It was a 18-month-old child presenting with this intracerebral and intraventricular hemorrhage. This baby girl was initially awake, stable, with no deficits. I was on duty at that time. And this, so we performed an MRI, which shows this vascular malformation, very deep, and it was paramesencephalic. So the plan was, as you can see here also the sagittal view, so the plan was, came on a Saturday, weekend, classic, and the plan was to refer her to a neuroradiological unit specialized in pediatric AVMs on Monday. So this is all what I had, this MRI. And on Sunday, I was called, and there was a deterioration in the clinical situation, in the clinical condition. She was now comatose and dilatation, or with dilatation of the right pupil. And so this became an emergency. So my plan when seeing the CT was carefully removing the bleeding, don't touch the AVM. But actually the AVM bled, so I had to approach it, and this is the early post-operative CT scan showing the clips I had to introduce. Actually, this was a real fight. I can remember very well. There are cases which you won't forget. This is one of them, and was an 8-hour excellent cooperation also with the anesthesiologist, a very experienced anesthesiologist. And so this is, fortunately, the patient did survive. She did not have any neurological deficits, and we performed a control angiography, as you should always perform in the pediatric AVMs, especially after some years, in order to see if the AVM is occluded and remains occluded, as it was in this case. And so this baby became a young lady 20 years after surgery. This is a recent image, and I got, every year I get a new image from her parents, and so a very grateful case. So my message is in chapter 7, treat the patient as you would treat your closest relative, and always before surgery ask the question, would you do this surgery on your closest relative? You have to answer this clearly, this question. perform a realistic benefit and risk evaluation for any surgery you are going to do, and discuss it clearly with and understandably with the patient or his relatives if the patient is not able to understand. Always consider to give the patient a realistic chance. Of course, there are indications or clinical situations where you are not going to do a surgery because there are no realistic chance, but as seen in this patient with the intracerebral hemorrhage, there was a realistic chance and she got it. I think you can learn a lot on follow up the patient, and as long as possible in regard to functional outcome, and in regard also tumor cases if there has been a recurrence or late recurrence of the tumor. So this is very essential for your own quality control of what you've done. So closing remarks, it is our duty to fight for our patients and do our best. And I think this fight is very often rewarded. And after you have done everything, leave the rest for the Creator. So with this, I'm closing my book. Thank you very much for your attention, and in these times, stay safe and healthy. Thank you very much.
Yeah. Thank you, Dr. Hischam Bassiouni. I hope I pronounced it. Hischam Bassiouni. Yeah, thank you very much, because I tried to pronounce it correct. Yeah,
No
you said you are like 30 years in neurosurgery, and it's really visible. Like, honestly, I'm impressed. Really.
Thank you.
I can say that, like, from not the neurosurgical background that I have, it was really interesting. It was understandable. You showed the great sequence of really different things you need to figure out being a neurosurgeon, and not only a neurosurgeon, even just a general doctor. Yeah, you have to take many things to consider, and also these examples of patients and how they feel after the operation. You know, it makes me smile after this, because you see your work done, and I'm sure when you finish your operation and see your patient, you feel like you are on the heaven now, because this is the greatest thing in the world you could do. So I really wish you to continue your medical practice, your career, and to teach more students, because this is really, like, really, I'm honestly impressed. This is really great presentation, and I'm happy to listen to it, even though it is like half of the night here as well. So, but it's really great. Yeah, thank you.
We're still awake.
Yeah, that's great. So thank you for joining us today. I would like to say thank you for our organizers, for Dr. Herrera, for Dr. Babakateb, for Dr. Salim Abdul Rauf, for Neurosurgical TV. They are also broadcasting us. So to the Francisco, to the Mexico team, and to all of you. So I hope to see you on Monday.